Can you guys see me okay? The slide deck okay?
Yeah.
Great.
Okay. Give people a few more minutes. Hello to those of you who have joined on time and early. We're just going to give it a few more minutes for others to join before we get kicked off. All right, well, welcome this Monday afternoon to the Prenatal through age 25 Behavioral Health Legislative Implementation webinar. We are happy to have you here. Just a few housekeeping things before we get started. We ask that you please mute yourself if you're not speaking. Raise your hand if you want to speak. This time is definitely for you, and we welcome any questions, comments, and feedback. We do have a loaded agenda today, so we are going to ask and hold questions until the very end. If you're like me and you can't remember till the very end, feel free to put it in the chat, and we definitely will be going through those at the end. And if there's something that we can't answer during this call today, we will definitely follow up with you after the meeting. A quick disclaimer that this Zoom meeting is being recorded and will be posted to the HCA Prenatal Child and Young Adult Behavioral Health Services page. This recording is open to public disclosure, so please do not disclose any private or confidential information. Like I said, we do have a packed agenda today. Monica will be going through family-initiated treatment, Sonia on the intensive outpatient and partial hospitalizations pilot. Mandy will be going over habilitative mental health, and also the children's long-term inpatient program expansion. Tina will touch on behavioral health respite. Kiki will be going through mental health assessment for young children. And last but certainly not least, Sherry is going to give us an update on the youth mobile response stabilization teams with 988. And we'll turn it over to Miss Diana if she has anything to add before we kick it off.
Hi, thank you, Jennifer. Everyone, thank you for joining today. A few stage setting for the day. My name is Diana Cockrell, and I get to support the amazing work of the Prenatal through age 25 Behavioral Health section in the Healthcare Authority. For context for what we're doing today and where it comes from, the last legislative session, House Bill 1800, gave resources to the Healthcare Authority to support communications for the Prenatal through age 25 Behavioral Health section. A goal of these resources is to increase the regular communication about our legislative implementation activity, and it funded the FTE. Jennifer Peterson, welcome to the team. So happy you're here to help us make sure we are communicating well and consistently. We have roughly 15 to 20 initiatives that come out of this section for legislative implementation, and we'll be sharing those updates on a rolling calendar that you can find on a link for the what's next slide. We're going to work on doing these updates monthly outside of the legislative season. There's more that the team does, so I want to flag that. There are a lot of folks doing a lot of really great work. This focuses on our legislative implementation work. So for each implementation presentation, you'll hear a little bit about the language that's in the bill or the budget proviso that funded it, and then a rough timeline for the work and where we are in the process of that rollout. Looking forward to your thoughts, questions, and feedback at the end of the presentation today. Please participate freely in chat as you'd like. We'll capture those questions and call them forward during the Q&A session, and perhaps answer in the chat as we go if we're able. And we look forward to sharing with you today. Thank you for joining us. And team, thank you for stepping into the space and sharing about your work today.
Thanks, Diana. This is a Meet the Presenters. These are the 6 presenters that will be sharing their information with us today. These are all linked on how to contact them. So if you at a later time want to connect with them on their particular subject matters, please feel free to reach out to any and all of them. And with that, I will turn it over to Monica to talk about family-initiated treatment.
Thank you so much, Jennifer. It's such a pleasure to have an opportunity to connect with you all today. My name is Monica Webster, and I'm the Access to Care Family-Initiated Treatment Manager for Prenatal to 25, school age for the Healthcare Authority in the Division of Behavioral Health and Recovery. So my plan here is to just provide a bit of an update on FIT. Okay. So FIT was initially developed based in part on recommendations made by the PIT, which stands for Parent Initiated Treatment Stakeholder Advisory Group. That advisory group included voices of youth, parents, clinicians, hospitals, emergency departments, and child system advocates. PIT, which was designed to accommodate acute inpatient evaluation and treatment, was longstanding and now has evolved into FIT, which provides a pathway for outpatient evaluation and treatment and other guidance associated with the FIT legislation. The stakeholder group's findings and recommendations were delivered to the Children's Mental Health Work Group in December of 2018. And in 2019, the legislature enacted Gross Second Substitute House Bill 1874. In 2020, House Bill 2883 was passed, adding residential treatment as an accessible treatment service through FIT. Okay, next slide, please. Thank you. So what is family-initiated treatment? Well, as I shared in the previous slide, what began as parent-initiated treatment, PIT, for acute inpatient evaluation and treatment, has evolved into family-initiated treatment, which is FIT is the acronym for that, and includes a residential treatment component. FIT provides an opportunity for youth to receive behavioral health care when they're not able to provide consent for themselves. FIT allows parents and professionals an opportunity for time-limited treatment where the parents can provide consent on the youth's behalf. And what we really try to encourage is collaboration between youth and the treatment team. Treatment works best if youth engage in treatment. The goal is to engage youth in the services they are receiving so they can consent to continue treatment as needed. Another aspect to keep in mind, almost there. Another aspect to keep in mind is that youth can change their mind to voluntarily consent to treatment, or the Involuntary Treatment Act, also known as ITA, can be enacted. Thank you. I'm ready for the next slide. Thanks. So I wanted to provide some cumulative data that we collected from January 2020 to September of 2022. And as you can see here, over the past 2 years, 9 months, there have been 1,600 FIT admissions, 243 FIT reviews, 33 SUD admissions, and 20 SUD reviews captured. Thank you. Next slide, please. So what's next for FIT? We've just wrapped up data from a short form survey implementation inquiry that was sent to parents, youth, and providers, which really serves as a precursor to our more expanded annual community survey, which will be sent out very soon. This information helps us to gather feedback on accessing FIT services and identify areas where we can improve. It also really provides valuable feedback for me as I engage with our constituents and partners through the FIT marketing campaign that we're actively executing right now. We also have the, so as I mentioned, the annual survey that goes out next year, the expanded annual survey and legislative report. And we are in the process of having the FIT modules translated into Spanish as well. So if you or someone you know would like a deeper understanding of FIT, these modules are completely free and available using both the QR code that will be provided at the end of this presentation or on the HCA website as well. We're just about done completing our FIT guide that'll house everything FIT to kind of ease accessibility to all of the FIT materials, forms, processes, so that you won't have to search in multiple places to access the information. And thank you so much for your time.
Thank you, Monica. With that, I turn it over to Ms. Sonia to talk about intensive outpatient and partial hospitalizations.
Hey, so it's hello. My name is Sonia Salazar, and good afternoon. Thank you all for joining today. I'm very happy to be here. I am the project manager over the intensive outpatient and partial hospitalization pilot programs. So I'm really happy to provide you an update on how our pilots have been going as we are going into the second year of services. And let's go ahead and just get into the background. So in 2020, through Senate Bill 6168 and in 2021 Senate Bill 5092, these required HCA to implement 2 pilot sites to provide intensive outpatient and partial hospitalization for children and adolescents up to the age of 21. This also is referred to as Proviso 76. HCA then contracted with the 2 hospitals that provided psychiatric inpatient services, in which one site is located on the west of the Cascades and one to the east of the Cascades. For the pilot, it was regulation to base the services in a psychiatric hospital serving adolescents and children. Next slide, please. So these services are to be offered in lieu of inpatient treatment. If services are available to any of the adolescent or child that are less costly or community-based, we are not to offer services to those individuals. Each of our sites have identified their own target population with criteria that must be met for the child to be admitted to our intensive outpatient and partial hospitalization programs. Next slide, please. Thank you. All right, so throughout the rest of the slides, you may hear me just refer to intensive outpatient as IOP and partial hospitalization as PHP, as these are the shortened versions for those. So let's look at the different varying factors that separate IOP from PHP and the difference in the level of care. So intensive outpatient individuals are not presenting as an imminent risk of harm to self or others, and they're more focusing on the level of care to generate maybe coping skills or to reinforce any acquired skills through group, family, and individual treatment. So this is also for when this individual returns to a less structured outpatient setting. Treatment services at minimum will be 2 to 4 hours per day and 3 to 5 days per week, with the average length of stay, I would say maximum 30 days, but we're seeing right now about 20 to 30 days. So over to the partial hospitalization or PHP. It really parallels the intensity of services provided in a hospital setting. This includes medical and nursing supervision as well as interventions. This is again an alternative to inpatient within the individual can safely reside in the community. Psychiatric oversight is needed for 5 to 8 hours per day of treatment, including individual, family, and group therapy. Also skills group, focusing on ADLs, school consultation, parent training, coaching, and parent partner services. So these are typically going to be 3 to 5 days per week, and these services will not exceed 45 days. Next slide, please. All right, so now let's get into discussing the roadmap on our pilot sites and programs that we actively have running at this time. So we did start in January of 2021 with Seattle Children's as our first identified site located to the west of the Cascade Mountains. Seattle provided in the beginning 3 virtual access IOP groups. We have the anxiety IOP, the dialectic behavioral therapy, DBT, or the obsessive compulsive disorder, OCD, all offered virtually. And then we went on to add Providence, located in Spokane in January of 2022. So Providence is currently running 2 IOPs and 2 PHPs, serving adolescents up to the age of 21. Seattle then shortly after added a 4th IOP option in February and May. So it was the disruptive behavioral IOP at a virtual access, as well as the eating disorder IOP virtual as well. So as we have renewed the contracts moving forward to state fiscal year 2023, both Providence and Seattle Children's are still currently providing services with all of those 6 programs in place. And we are currently adding a stabilization, partial hospitalization in person through Seattle Children's. Our next steps are to implement services in a 3rd site, and we are still in the negotiation phases of that as we speak. Next slide, please. Okay, so this is just a small data update that allowed us to capture services for 67 youth. These individuals were served from March of 2021 to February of 2022, which is a whole 12-month time frame. These youth were served within the 6 programs that were offered between Providence and Seattle Children's, and all captured with just identifying what each child and youth that attended each of those programs. Next slide, please. So outcomes for the youth have really showed programs appear to be trending towards delivering positive clinical outcomes. 76% were discharged to a home placement, and a small 4% were discharged to inpatient or emergency department. Next slide. All right, so our next step. So HCA is contracted with Mercer. We are contracted to provide guidance and recommendations and cost and program outline to the Medicaid state plan. Excuse me. So Mercer has created our standard reports to provide to legislator with any program updates, as well as our progress reports. And we will continue to, us at HCA will continue to work closely with Mercer on actuarial projections on the statewide need for services related to the pilot sites, estimated cost of adding each of the services to the Medicaid behavioral health benefit for children, adolescents. Through Senate Bill 5736, we have started bi-weekly meetings with our Medicaid partners to work closely with the recommendations from Mercer, as well as requirements from the Center for Medicaid and Medicare and Medicaid Services to implement services for our IOP and PHP into the state plan. So this is my update for the pilots, and I really thank you all for giving me your time today. And if you have questions, I'll look forward to answering them in the slides for the chat. Thank you.
Thank you, Sonia. I will now turn it over to Mandy to talk about updates on habilitative mental health and CLIP.
Thank you, Jennifer. Hello, everyone. My name is Mandy Huber, and I'm a Children's Behavioral Health Administrator on our Prenatal to 25 team. And we'll be talking about habilitative mental health as well as children's long-term inpatient programs. So to start out with habilitative mental health, or HMH, as I will refer after this. This is a new program that the legislature gave us funding for in July of 2021 to contract for a 12-bed children's long-term inpatient program, or CLIP, as I will refer to, facility, but specializing in habilitative mental health. So the HMH services will be for children and youth with intellectual developmental disabilities who have really intensive behavioral health support needs. And then we are also to provide data on the demand and utilization of the facility by June 2023. So just a little discussion about implementation and challenges. Healthcare Authority issued a request for information in January 2022, and essentially no providers applied, really due to workforce shortages and a low daily rate, as well as no capital funding was available. So Healthcare Authority developed an advisory stakeholder committee where we have specialists, providers, and other system partners that work with us, and we convene a meeting at least once a month, sometimes more, to really work on building the program. As far as, we discuss that what the current legislative funding is for, and also what is needed to really stand this program up. So we've talked at length about cost modeling and staffing modeling to ensure we have the right specialized staff for the program and the funding that is needed. And so we are just continuing to work to find a provider who wants to create this new innovative program and scope of work that we really do not have in this state, and we know that it is desperately needed. And just continue to work with the current funding we're giving to see if any providers will take on this new program. Okay, children's long-term inpatient, or CLIP, as I talked about. Just to give you an overview, CLIP is the most intensive long-term inpatient psychiatric treatment available to Washington State residents. It is funded by a 50-50 match of federal and state Medicaid dollars. CLIP is a planned inpatient treatment course that includes multidisciplinary psychiatric treatment. The goal of CLIP treatment is to transition the child or youth back to their home, family, and community at the earliest clinically indicated time possible. So expansion and implementation. Healthcare Authority is working to increase the number of beds and rates for contracted community programs, CLIP providers and programs. The number of beds will increase on a phased-in basis to 62 beds by the end of fiscal year 22 and to 71 by the end of 23. The rates are increased, had already increased effectively July 2021, and by an additional 4.5% effective at January 2023. And so CLIP bed capacity, currently the bed utilization changes daily with admissions and discharges, sometimes transfers if there's another CLIP facility, although it's rare. Sometimes there's another program that might be more appropriate for a child or youth. The current available beds is 52 beds, and the monthly average utilization is 37 beds. So concerning providers, we are working to identify potential providers. We have identified them who would like to start some new CLIP programs, as well as our current programs adding more beds. We have interested providers touring CLIP facilities. They have already, some have, some are scheduled. And then we continue to have discussions with other providers who would like to stand up CLIP beds. And so challenges, much like I talked about with habilitative mental health and across the board in behavioral health, there's workforce shortages, and meeting staffing requirements is really a constraint for current providers. Other constraints are competitive rates to hire and retain staff. The programs often struggle with other private providers that might pay more. So that is kind of a work in progress. And then other constraints are just the permitting and licensing process, which can be slow. And that's it. So appreciate everybody who has joined, and look forward to hearing any questions you may have. Thank you.
Thanks, Mandy. Now for Ms. Tina for a behavioral health respite update.
Thank you, Jennifer. Good afternoon. My name is Tina Burrell, and I'm an acting supervisor with the Prenatal through 25 Behavioral Health section in the Division of Behavioral Health and Recovery at HCA. And today I'm providing an update on efforts to implement behavioral health respite care for youth and young adults. First, I want to provide some background information. I want to share the current definition of respite care services in behavioral health, and that is the observation, direct support, and monitoring to meet the physical, emotional, social, and mental health needs of an individual by someone other than their primary caregivers. Respite care should be provided in a manner that offers necessary relief to the caregivers, and respite may be provided on a planned or an emergent basis and may be provided in a variety of settings. I do also want to highlight that behavioral health respite is not a Medicaid service. However, it is allowable with other funding, local or federal. Also would like to provide an example of what is respite. We have an example that's been funded through federal dollars under the System of Care grant. And under that, they have offered overnight respite services, day respite services, an after-school respite program, and family supported with peer coaching while also receiving respite services. So that's a bit of the background, and on the slide, you'll see what's happening right now. We were directed by Proviso 82 that Healthcare Authority would contract with Mercer Health and Benefits to evaluate options for a Medicaid waiver, so it could be funded under Medicaid, to provide respite care for youth experiencing behavioral health challenges. And with that, we have options in the technical report that provide some context for Healthcare Authority to evaluate potential avenues for establishing this benefit. The options also identified in the Mercer report take into consideration existing respite benefits provided by Developmental Disabilities Administration and the Department of Children, Youth, and Family. We certainly do not want to cause any adverse impact to already existing and much needed respite services. The technical report by Mercer was completed on June 30th. You are welcome to review that report. It is posted on our website. There's the information and link there. We've also created a companion document, a one-pager, that shares some of the history about this effort and this initiative. We'd like to honor that the request for respite across the state was first brought to our attention through Family, Youth, and System Partner Roundtables, FISPERTs, highlighting the need for youth and caregivers and families to have access to respite. And this information then moved forward and elevated to the Children and Youth Behavioral Health Work Group, who took it upon themselves to identify it as a recommendation. And now we have Proviso 82, which we've completed that. It's also my understanding that the Children and Youth Behavioral Health Work Group are continuing with a recommendation for HCA to follow up on these options and also support the pilots that we've seen under the Systems of Care grants or similar pilots and work. So we are grateful to that historic work and want to honor them for bringing that forward. And our job now at HCA is next steps, what's happening now. And we are reviewing those options in the technical report and having conversations about what we could move forward. So as you've heard from other presentations and from Diana's opening, we are providing these updates frequently. And so in the coming months, you will learn in real time kind of how we want to move this forward and what options would fit for Washington State. So thank you for your time and any questions, feel free to put them in the chat. Appreciate it. Thank you.
Thank you, Tina. Now, Kiki will give us an update on mental health assessment for young children, otherwise known as MACI.
Hey everybody, my name is Kiki Fabian. I work on infant and early childhood mental health programs at HCA. I'm first off going to start with a little bit of background on how do we think about developmentally appropriate mental health services for young kids and their families. When kids are at this age group, which we usually think about birth until they turn 6, they're in a really unique developmental and relational space. And when working to support their mental health providers might need additional time to understand the strengths and concerns of the child and the family in a bunch of different areas, their physical health, their developmental milestones, what's going on in their social lives, what's happening in the context of relationships, and finally in their behaviors and their emotions. Providers might also need additional support for meeting families in comfortable settings, like at their home, their preschool, Boys and Girls Club, so that they can see families where they're used to being together and they can really observe the child's behaviors in real time. And lastly, providers might need special language for understanding themselves and explaining to parents what mental health even looks like in early life. So we might have some preconceptions about what depression looks like for an adult, but what does depression look like for a 3-year-old? That can take some additional time for folks to think through and to understand. So we can move to the next slide. So similar to what Tina shared, this legislation came out of the work of the Children and Youth Behavioral Health Work Group. It was passed in 2021, called House Bill 1325. And it creates some new policies for how the mental health assessment or the intake evaluation or the diagnostic evaluation happens for really young kids enrolled in Apple Health. 2 of these pieces are around reimbursement policies. So making sure that providers are paid to provide the services that really are developmentally appropriate. So allowing providers to get paid for doing assessments that might take multiple sessions. You might need more than one meeting with the family to really understand what's going on. It also allows reimbursement for when providers are traveling to home or community settings. So they're getting mileage rates for that time that they're spending in the car driving out. And lastly, there's support to use what's called the DC 0 to 5, which is very similar to the DSM, but specifically designed for young children. So it includes additional disorders and diagnoses that you wouldn't see in older children, youth, or adults, and also developmentally appropriate criteria for what those disorders look like in young kids. So we can go to the next slide. So since this passed in July, or went into effect July 2021, HCA has been busy kind of putting all the different resources and supports in place to help this happen for folks. So all of the reimbursement policies went into effect January 2022. And since then, we've had a bunch of different billing guidance and webinars that are available on our website. We have a web page for this effort, which Jennifer said we abbreviate to call MACI, but stands for Mental Health Assessment for Young Children. And if you head over to that webpage, you can find billing guidance, webinars, resources to help you understand how to access those reimbursements. There's also some additional tools for best practice. One key one is the DC 0 to 5 crosswalk. So that helps providers connect a DC 0 to 5 diagnosis to what's the appropriate ICD-10 code that they put on their claim that's required for billing purposes. We're also really excited to offer free trainings to providers and to allied professionals who work with young children and families in how to use the DC 0 to 5. This is done through a project we call the Infant Early Childhood Mental Health Workforce Collaborative. Ooh, that's a mouthful. And they are now starting to provide communities of practice for folks who've gone through the DC 0 to 5 training, as well as other trainings on assessment and diagnosis that help support providers in this work. They also have a webpage where you can find out about trainings, resources, and sign up to be on their email list. We'll go ahead and put the links to those in the chat. And if you have any questions, our contact information and other resources are available at the end of the slide deck. And that's all I've got for today. Thanks, everybody.
Thank you, Kiki. And now we'll move on to Sherry for the Youth Mobile Response and Stabilization Services.
Hi, everyone. My name is Sherry Wiley. I am the Mobile Crisis Team Administrator for Youth and Families here at Healthcare Authority Division of Behavioral Health and Recovery. And I'm going to talk to you today about 988 and the expansion for crisis systems moving forward for youth. As you know, in 2020, 988 was designated as the National Suicide Prevention Lifeline. In 2021, Washington passed engrossed second substitute House Bill 1477 to implement 988, and this bill created a crisis response improvement strategy committee and a steering committee who will make recommendations to legislature on crisis system enhancements moving forward. As you may know, 988 went live on July 16th of this year. All other crisis lines remain active, and calls to 988 are being routed to one of 3 national suicide prevention lifelines. All other crisis lines and regional lines remain active. HCA is working towards best practices in alignment with SAMHSA for someone to call, someone to come, and somewhere to go. We are working on best practices for mobile response teams, which includes peers responding in pairs of 2 to the person in crisis. So a peer and a clinician paired together. Next slide, please. This is a slide that talks about the difference between youth versus adult mobile crisis. Crisis services are historically adult focused, including here in Washington, and designated or designed for more acute presentations. Youth and caregivers typically access the crisis system by calling either 911 or going to the emergency department. With the expansion of 988, we are working towards best practices for youth under the Mobile Response and Stabilization Services model. This model is designed as an upstream intervention to send help when and where people need it. Youth and caregivers are interconnected, so when a youth is in crisis, it can impact a parent or caregiver's ability to de-escalate the crisis. We want to send help when people need it, when they ask for it. If a parent is calling 988, we want to get out there in person and assess the situation. This will help reduce unnecessary contact with law enforcement, child welfare involvement, out-of-home placements, or residential care. The youth, young adult, parent, or caregiver define the crisis, not the call taker. They call and teams go. Teams will respond without law enforcement, and youth teams are trained in developmentally appropriate de-escalation, trauma-informed care, harm reduction, and safety planning. Next slide, please. The youth model includes 2 components. The initial response and follow-up can last up to 72 hours. This is the initial response, and there's safety planning and assessment of needs, including identifying strengths, what's already working with the family. Since this may be the first point of contact a family has with the behavioral health system, the team should build a trusting relationship of mutual respect and provide individualized care that includes family voice. If after the initial response, the youth or family needs additional support, MRSS has a separate but connected in-home stabilization phase. This phase can last up to 8 weeks, and teams work with the family and system partners to keep the youth safe at home. With the family, teams identify natural supports and connect families to them, and these promote opportunities of natural respite. If additional clinical supports are needed, teams provide warm handoffs to those providers for ongoing support. Next slide, please. These are the goals of MRSS. We want to keep kids in their natural environment. They sleep in their bed at home, not in facilities, and they return to school. A youth mobile response team should have robust outreach and engagement with all child-serving systems and system of care partners and providers. They promote safety in all environments kids are in, and they work to reduce contact with law enforcement, juvenile justice, and eliminate unnecessary emergency department use for behavioral health needs. And they assist families by identifying community and natural supports and providing warm handoffs to those supports. This model can be used across the lifespan to include transitional age youth, adults, and older adults. Next slide, please. Washington is divided into 10 behavioral health administrative service organizations, and HCA contracts with them to deliver crisis services statewide. Adult crisis teams exist in some form or another all over the state. The smiley faces represent the youth teams that existed at the beginning of this calendar year. Those are in King, Pierce, Thurston Mason, and Southwest and Clark County. In 2021, proviso funding was sent out so that each region could have at least one youth and adult team in preparation for 988 going live. The regions funded for youth teams were Spokane, Greater Columbia, North Central, Great Rivers, Salish, North Sound asked for 2 youth teams, and Southwest was enhanced to bring the youth team up to 24/7 coverage. The regions are in various stages of standing up teams, and even with this expansion, gaps remain across the state. Next slide, please. This slide shows in days how much service a youth gets when they enter the crisis system. So on the left side, the first 3 days is insurance blind and provided to everyone in Washington for crisis services. The longer lines represent the stabilization phase. 2 regions have been doing the 8-week stabilization phase for some time, and these include King for Medicaid youth and Thurston Mason for all youth insurance blind. This is done through braided unsustainable funding because our current state plan only allows for 14 days of stabilization. You'll see an orange line in 2 regions, that's in Pierce and in Spokane, and that's because Healthcare Authority's Prenatal to 25 team applied for and was awarded a system of care grant through SAMHSA, and that will allow both regions to begin offering the 8-week stabilization phase. The picture on the left is where we are today, and the picture on the right is the goal. This is what we are working towards through crisis system enhancements called for in House Bill 1477 and the ongoing work of the CRIS committees. For info about our crisis system enhancements, you can view our decision package on the Office of Financial Management's website, and I'll put a link to that in chat, along with the CRIS committee page and a video about youth crisis services. Thank you for your time, and feel free to reach out with any questions.
Thank you, Sherry. So now I will open it up to the team. I'm going to stop sharing and open it up for Q&A. I see that there are some things in chat, which I have not been able to see. So let's see, shall we? So first one would be to Monica, and I apologize if you've already answered these in chat, from Ashley, saying, to clarify, youth are welcome to engage on a voluntary basis into services and also disengage in services at will. Yes?
Yes, thanks, Jennifer. Yeah, I just finished drafting the answer for Ashley. I'm working through them. I'm so sorry, I'm so slow.
No.
But the answer is yes. So youth 13 to 17 can voluntarily access care anytime with or without FIT. So, you know, we know that the age of consent is 13 here in Washington State. And under FIT, a parent can provide consent on the youth's behalf. And so that means that the youth does not need to provide consent for the initial 12 sessions. But after that, they would need to consent for continued treatment unless they're reevaluated by a new provider. And then those 12 sessions would begin again. So I'm hoping that that makes sense, Ashley.
Yes, that makes perfect sense. Thank you.
Okay, thank you.
And then from Michelle, do you have data for the pilot programs? And then regarding FIT, what do you mean by review?
So this is Tina, and I believe Ace Bolger, who oversees the System of Care grant, help support that, is sending the report to Michelle. Thank you. Ace.
Ace.
Thank you for asking, Michelle.
Yep, it's on its way soon.
Oh, I see. You're right. Look at you guys. You guys are so on top of it. Are there any other questions that the group would like to ask the team? I think everything's been answered in the chat so far.
Jennifer, to Michelle's question on what does review mean in FIT, I'll take a stab at it, and Monica, you can correct me or add or adjust if needed. Part of the implementation of family-initiated treatment was wanting to make sure that kids didn't end up in care without somebody having oversight about the clinical need for that care. So the review means whatever level of care they're at, whatever the timing is per statute that we're required to review it. It's that clinical second look to make sure that there is a need for the young person to be in the treatment that they're in, and kind of watching for that second lens to ensure that young people aren't in care against their will without somebody else making sure there's clinical need. Monica, anything or anyone else? The team's pretty familiar with it. You would add or change?
No, that was
adjust
perfectly
my
put. Thank you.
response?
Thank you.
Okay, okay.
Thank you, Diana.
I also want to say thank you to Kiki for putting a link to the slides in the chat. Everything that we discussed today does have links within that presentation. So thank you, Kiki, for sliding that in there for me. I open it up to any other questions.
I like to frame this part as we're all learning together how this is going to work, with question and answers at the end. So even if it is about things you're curious about, perhaps that are involving kids' behavioral health that we may or may not be connected with, it's a place to ask your questions, and we may or may not be able to answer today, but we're happy to take it back and follow up. And we're curious about what people are curious to know about. So appreciate the questions that have come in so far, and feel free to share also things that you think we should be aware of that sound similar, that are needed, that your thoughts and feedback about things that you've heard or seen. Again, we may not have an answer today or be able to respond today, but happy to listen and follow up as we're able.
I have a question. I guess I could ask the team one between Monica for FIT and Sherry for the 988. Do your two programs intersect anywhere? And are you guys working together on connecting kids between the two? One being in crisis and then one maybe leading as a warm handoff to FIT.
Well, I can start with that one. I know that my experience with crisis services, I've supervised crisis services in the state, and the provider that I worked for at the time did participate in the FIT, the parent-initiated, the family-initiated treatment. And so I have seen it work with crisis services, and it's very effective, and teams are going to be trained in engagement with youth, because when you get to that 13 to 17 age range, what's really important is that you have a clinician and a peer that can go out there and engage with that youth. And while the youth may initially be entered into crisis services under family-initiated treatment, we've seen a huge success rate in getting that youth to ultimately sign for themselves for their own treatment, because they see the value in being the driver of their treatment. So great program. I really like FIT for that reason.
Thank you, that helps. Any other questions?
Think I got the go ahead to ask this as a canned question. Jennifer, what programs will be at the next webinar that we're doing like this?
Oh, sure. Oh, she's gonna put me on the spot. I know
Oh,
that rehabilitative mental health for sure will be on the agenda, as well as CLIP. They will be monthly presenters for us. We will have some family navigator, I think is on the hit list for December as well. There's about 9 additional presentations that will be new to the December body of work. But they're all listed out on the website. The full agenda is out there, so anyone can access that. Oh, look at there. Miss Kiki, she's always on it. Thank you.
My millennial gift. I know how to use it.
Yes. Maybe one for Sonia on the new pilot programs. I know that you guys are looking to set new ones up into 2023. Do you have any specific areas that you guys are looking to expand into?
We're just in the negotiation phases
Oh,
to
early.
work with at Lake Burien at a multi-care site. So we are just hoping to finalize that here shortly and looking to hopefully implement within January, February of next year. And that will be for a partial hospitalization.
Anyone else? Any other takers? If no, like we said before, look at me all over the place. We did include some additional resources for you guys. So these are all the links to FIT that Monica talked about today. These are the ones for the infant early childhood mental health that Kiki informed us on today. And again, these are all linked. And then also a link to Sherry's team for the youth mobile crisis team and services and how to get a hold of them. And with that, thanks guys for coming. I hope you have a wonderful short week and travel safely if you're traveling. Enjoy families and all the things during this week. And we'll talk in December. Hope to see you soon.
Thank you.
Thank you.
Thank you.